On 8th July, a UBC crew set off for Ivukula sub-county in Namutumba district. We were hosted at Ivukula Health Center 3 for a medical camp organized by Zadok and Joyce Wobulembo Memorial Foundation. In rural areas, access to medical facilities and doctors is limited. This is mainly because of limited hospitals, clinics, and qualified medical personnel within close vicinity. Medical camps provide a stopgap measure enabling people in remote villages to see a doctor, sometimes for the first time in many years. Medical camps also play a critical role in providing free of cost medical care and creating awareness about health issues in such areas. It was evidently written out on the faces of the locals that they needed help, and it was timely. First, we were able to talk to the senior clinical officer who shared a brief about Ivukula Health Center 3.
My name is Goreti Chevaja. I am a senior clinical officer. I'm in charge of Ivukula Health Center 3. Ivukula Health Center 3 is a government-aided health facility that initially started as a community hospital, a community facility, then later was taken up by the government as a health center 3. It serves a catchment population of about 17,000 people with the 7 parishes located not very far away from each other. So in Ivukula Health Center 3, we offer a wide variety of services that include both curative and preventive. To mention but a few, we have HIV counseling and testing, antenatal services, family planning services, TB testing and treatment, pediatric services, nutrition services, a number of them. I may not mention all of them. So it has both inpatient and outpatient departments, and we also have a component of the community where we have outreaches set out to meet those needs of people who may not be in position to come to the facility. On a weekly basis, we have outreaches that are sent to the different places. The medical camp is one of those best services that benefit the community. It is, if possible, it is one of the services that all facilities would have loved to offer. However, given the financial constraints that we have as facilities, we are not in position to hold a bigger kind of camp like this one. So the foundation saw the need of the community, because usually when they come to the facility, we have issues of sometimes we can have stockouts, sometimes, and in most cases, not all services that are offered in this camp are offered here daily. So they would miss out on a number of services. So organizing something as big as this, where we have consultants, obstetricians, pediatricians, surgeons, coming in a level 3 facility, is something so innovative and so productive for the people to benefit from. So when the founders of the foundation saw the need of their community, giving them back a service was one of the things they thought about. This is not the first camp. We had more 2 camps previously. And the turn-up was also overwhelming. That significantly tells how needy the community is. So accessing this and providing it to the people is really something very good that benefits the community. So we really appreciate them for putting in a lot of money to see that this is a success. The second time they had a camp here, we as a facility benefited because we have infrastructure renovated. That would not have happened if it wasn't for the camp, given the financial constraints. We are really humbled. And then when they come, they look at, we can call them needy people You see someone is in need, but they don't have the capacity to help themselves. So they would register, they would have a list of those people who would need further care. For example, they may need bone replacement that may not be done here. So they are facilitated and taken to hospitals where they can benefit. So someone deep down in the village cannot afford a surgery, but gets a free surgery at no cost, all courtesy of the foundation. We've had women, the elderly, getting treatment, getting those medications for their bone issues is a challenge in health center 3-level facilities. So when they come and get their medicines free of charge, they go back with pain reduced. It is one of the best stories they can share. I want to say that this should be the way to go. Wherever possible, if funds available, wherever you have probably funders or donors who have the heart willing to give back to the community, this should be the way to go, because the community gets the best service at no cost at all. So this would be something to invest in.
The family members, doctors and volunteers were dressed in blue branded t-shirts. What caught our attention were the wordings on the t-shirts, that is, the 3 pillars of the foundation: compelled by love to spark community to sustainable health, wealth and education. We got a chance to talk to the family members and founders of Zadok and Joyce Wabulembo Memorial Foundation, who shared the history of the foundation and why they opted to host medical camps in Ivukula sub-county.
My name is George Bamgeberere, and I am an advocate in Kampala. I studied law, therefore, but I'm a son of Zadok and Joyce Wabulembo. Zadok and Joyce were both primary school teachers, and they taught in many places. Taught here in the Ivukula, taught in Kaliro, taught in Kokonjeru, taught in Busubizi in Mitiana. So we were really a roving family, and they would take us along. So we were born 10. We are now 9. One of our brothers died, and the parents died. The father died in 1989. So that is 35 years ago. Then our mother died in February 2020, just before COVID. We are here because after our mother died, we got together and tried to analyze the cause of death. She basically had been all right. She fell sick. We got a call in Kampala. Mom is not feeling well, but she's suffering from diabetes and a bit of pressure. So we had a practice. Whenever she got sick, we got to the first health care facility, Health Center 3 or a dispensary, to just make sure she's stabilized. Then we'd send a vehicle to transport her for further medical assistance in Kampala. So on this occasion, when she was taken for a first aid at a health facility in Iganga town, they carried out some routine tests, and they said, she's suffering from mild malaria. We checked on her the following day, and she said, she was actually talking. I remember the health person, the doctor telling us that, by the way, I'm discharging her. I could even discharge her today, but let her stay for an extra day. I'll discharge her tomorrow. We asked routinely, can you please take her pressure? Our doctors took the pressure. And her pressure was slightly lower than mine. So I remember getting embarrassing. I'm a younger man, and my mother's pressure is down. Obviously, no one had the capacity and technical knowledge to know that it's a bad sign. Somebody suffering from pressure, her pressure is going down. Anyway, the next day she was to be discharged. We got a call. A call came from her in America. Harriet said, by the way, I've been in touch with the person attending, and mommy is unconscious, you know. So we were traveling to attend a funeral. Actually, we were in Imbala at that time, heading to Dokolo to attend the funeral of a certain judge's mother. Then, so we turned back. By the time we come back, she's actually unconscious. She can't talk. The person should have been discharged the previous day. Then we did some FaceTime with her in America. She's a critical illness doctor in America. So we did FaceTime. And then she sent us a small message saying, by the way, if you don't get her into ICU in 3 hours, she'll die, you know? So we got, the government actually helped, even set us a helicopter. Unfortunately, as the helicopter was landing, she died. Why have I gone through that story? That story reflects the situation in our area. And we are not even, it's not as though we've carried out a survey of the whole sub-county or county, but I can tell you our little village called Bulembo, 90% of all the deaths have been out of preventable causes. We have a person, one of our aunties was trying to help with construction of a house. She was in her 60s, collapsed, died in a few minutes. Turned out it was a heart attack. Our friend there, our sister, our niece, we had a cousin here, her father, suffered an intestinal obstruction. But there was no vehicle around in this whole village. By the time they got it to the hospital, he died of intestinal obstruction. Our grandmother was taking evening tea. As she's taking the tea, she dropped from her chair, dropped dead. Got cut, suffered cuts, died on the spot. So we just realized that actually there is a serious health challenge in the area. Because you've got case, every story, there is a story about everybody. People who, if they had access to a skilled medical service provider and facilities were there in time, many of our people would not have died. So as a family, in honor of our parents, we decided to start a foundation. And this foundation had 3 to 4 objectives. Number 1, addressing the immediate issue of healthcare within our limited resources. What can we do to address the health challenges that our people face? So that's how we came up with this initiative. Can we do something once in a while where we can do mass activity, testing people for preventable diseases or lifestyle diseases, things that they can't access. That's number 1, dealing with health. So we've done, this may be, is it the 4th or medical camp? Yeah, 3rd medical camp. And the numbers have been growing. You know, first one I think was 800, next one 1,000. Last year we were here and we treated 1,500 people in 3 days. Because people have ailments here, so many. Some undetected. And there's a practice here, you know, that when people feel very sick, they move them from a bedroom and then they put them in the sitting room, make a bed for them and wait for them to die. That's the practice around here. And it's really an act of surrender, you know. But is it true? Yet when we go to developed countries, you see somebody in a very bad state, But because there are facilities, there are skills, you know, medication, the person comes in coma and after a few days or weeks goes back. Son, why can't we have that benefit here? So that's what we try to do. It's a very modest. We think that one day if we've got resources, we'll actually build a facility with the main aim of first of all providing first aid, because a lot of the challenges happen at first aid level. Can we provide first aid? Can we actually find diagnosis? Because I told you our mother's case where I said, we found mild malaria. And the next day the person dies. Imagine what we feel, you know? When you do post-mortem, you say, is it something called sepsis? And it's treatable, you know? If you're in the right hands or somebody who can detect, that can be addressed. But yeah, the person died. She would be here because she was strong. She had no other problem. But there was nobody to diagnose and say, this, the symptom of this. And this. I mean, I told her on phone, I said, you know, as we are leaving mommy's room, she threw up. And she was in America, she said, bad sign. There is an infection. You know, nobody could detect that. So we want to deal with this health thing, increase awareness, provide first aid, provide correct diagnosis. Because when you have diagnosis, at least it can help you to find what? The appropriate intervention. So that is one area of health. If we get facilities, we would like to partner with the government, put a facility where people can go and diagnose the problem. You know, can we have a doctor who can accurately diagnose the real problem is this, and the intervention is, and even if the intervention is not available, at least they can signpost you to a place where you can get the intervention. It could be Iganda, could be Jinja, could be Kampala, could be abroad, but at least let the diagnosis be correct. So that's number one. So here we do the diagnosis, we treat, we provide free medicine. And one may ask, where do you get the money? We actually fundraise locally, local and international. Harriet, there's fundraisers from America, talks to friends in America. We also talk to people here, use our little resources to just provide this intervention. And it's really, really highly appreciated. And when we treat, we also give somebody something to eat, because there are people who are coming here that are absolutely hungry, yes. So if you can get a chapati or a soda, those are sort of things. We want a holistic sort of treatment. So that is one. The second one is economic empowerment. One of the challenges here is there is brain drain from the villages. People fear to come back to the villages because the one salaried person in this village will be looking after 1,000 individuals who have no income, have no job. So we are now talking about economic empowerment, and one of our brothers has been championing that. He's been going, training people. We brought somebody from Rukunjiri who has been training people here on fish farming. So fish farming, we've also got good breeds of goats, which are helping change the quality of goats in the area. They've also brought some Frisian cows, and we are trying to just improve the breed of livestock. That is, some of it got into poultry. But most importantly is that we've been teaching people, do something for yourself. Don't sit back and wait for the government to help you. And we are surprised that out of the fish farms that people have set up, even yesterday we were buying fish from our backyard by the community, you know, 10,000 each. They call it Mali. I don't know, they call it in Luzungu, but Mali. People are selling to us yesterday. And we've seen, and they've sold to many other people. So we are really happy about that we already see interventions are working. People are harvesting fish, there's poultry, we are seeing the livestock is improving. There is an extension worker, a doctor who goes around and helps us with our livestock. So we are seeing that there is a improvement in livestock. So economic empowerment is number. The third intervention is about education. We are conducting awareness in schools. As part of the medical camps, we always go around to schools to create awareness, how children can take charge of their lives, how they should be responsible, how to deal with the diseases that the common diseases that affect youth and so on. So that's an exercise we did. Last year it was very successful. We are going to do the same. And when we do that, we also carry some provisions, sanitary pads, reusable sanitary pads. So Harriet has brought some. I hope she'll show you samples. This has reusable sanitary pads, which she bought in number. Friends of America have donated this. We are going to distribute to people. This contains a piece of soap, hand sanitizer, toothpaste, deodorant. Now you know many of our age did not use deodorant until we got to University of Kampala. So now somebody in America has done this, and it's a family which said, we just want to bless people in Africa. And they designed this bag. They've packed, I don't know how many, 100 pieces or so, which we want to pass on to children here. So that is something, one of the things that we are distributing. But then there is this usable, they are called reusable sanitary pads. We bought quite a number. I don't know if I'm allowed to open. Maybe let's open. You see this? Huh? Yeah. So you look at this. It's reusable. Somebody can wash. It's very soft, comfortable, and reusable. So we are distributing this. Again, from contributions from friends. So we shall be distributing this in schools when we go around the schools. So all these are donations from friends, which we are distributing. Obviously, there is a problem. How do you carry when somebody you are traveling from America? How many? Then if you had 1,000 of these, you know there is transporting and so on. So some of these are symbolic, but we hope that we are also we are involved in improving the education. We also want to inspire children to love school, to love education, to study. Because interestingly, most of us started our education. We are in Ivukula. You know, we started in Ivukula. Geoffrey actually had quite a number of years in Ivukula. That is gone ahead to become a PhD in ophthalmology, you know. Harriet was born, he didn't go to Ivukula, but also went to some schools here in Busoga, and all these people have all got doctorates in medicine and so on. So we are trying to inspire children, saying, please, wherever you are, work hard. And then lastly, is a mindset change. A mindset change. There are a number of people who sort of lost hope. They say our situation is not getting better, despite the numerous government programs, PDM, yoga, and so on. I don't know, some people don't seem to be insulated from all this. So we are also saying, do something. You can be the PDM, don't even wait for the government. You can actually start small and do something without even borrowing money. Do something and build. Because Uganda, we are fortunate. We have very good soil, we have good climate, so people can actually help themselves. So it is all these sorts of interventions that we'd like to put together and improve our area, because this is where we are born and we are concerned. Even the Bible says that go and start from where? Go to Jerusalem and so on, but I think there is a verse like that, start with your own people. So we are also trying to help our people and inspire them. So today we are here to start this medical camp number 3 here in Ivukula. We thank the government for availing us this Health Center 3 facility, because we needed the context. But we've spoken to Permanent Secretary, Minister of Health, Director of Medical Services, the District Health Director, the RDC, they are all supportive. So we like this partnership with the government. They have the facility. So once in a while, we come with medicines which may not be available in national medical stores, but which are approved and very good quality. We are distributing. And then we've been surprised to have Ugandan partners as well. We had our friend's Case Clinic has donated to us so many things, masks, sanitizers, and so on. The things that we are distributing here. So we think that there is momentum, and through initiative of the community and ourselves, we think that we can spur development through these sort of initiatives. I thank you. So we have 3 days, today, 8th, 9th, and probably 10th. We will be here to provide these services to the population. And the population, people come from far and wide. I've had people even calling from Jinja who want to come and see doctors here. Yeah. Because remember, we are really bringing you the best. We've got doctors of different specialties are here. They've come. We have an eye specialist, a top eye specialist, an eye doctor. Then we have these doctors from United States, you know. You know, in that country, there's accountability. Everybody who dies, somebody must explain why they died, even if they are 100 years old. Now, to get people with that ethic in our community is also very good, because, you know, there are a lot of things here we rationalize, but these people have a different mentality that you must be accountable. So we are seeing people coming from far and near to try and access the kind of services that you would not be able to get. I'm called Dr. Geoffrey Wabulembo. I'm an ophthalmologist by training and subspecialized in pediatric ophthalmology. I worked for the public service for 27 years. Most of the time I worked in Mbale, but my final assignment was at Mulago National Referral Hospital, where I was the senior consultant ophthalmologist. Currently, I work for an organization called Light for the World as the International Medical Director for Eye Health and Neglected Tropical Diseases. I was born here in Ivukula and went to school, primary school here in Ivukula up to P5. So that sort of background inspired me to, together with the family, to see what we can do for our community. Because I've had opportunity to serve in various parts of the country. We were doing a lot of surgical outreaches in eastern Uganda when I was based in Mbale. And it just gave me an idea of how much need there is in the community. Because each time we went out, we would see hundreds of patients, operate on several of them, but still more and more kept coming. So I'm aware that there is a big need in the community. And our community here in Ivukula is not unique. There is similar need here for health services. Looking at adults, especially the elderly, we found a number of people who are actually living with blindness because of cataracts. And yet there's an intervention for cataract blindness to restore vision. So some of them had resigned to themselves to that situation, saying that, well, I'm old and, you know, old age comes with poor vision. So I realized that awareness is not yet really at the level where we want it to be, where someone knows that, okay, my vision is deteriorating, I should seek medical advice. Many times people develop these problems and think that they are part of old age. And then some of them are diseases that are treatable. Then the other problem is that this area in the past was a hotspot for trachoma. So there are some people who are having complications of previous trachoma infection. There's a complication we call trichiasis, where you get inturned eyelashes, and then the eyelashes rub on the eyeball. And unfortunately, when they rub on this clear part of the eye, in time it becomes opaque and results in blindness. So we had quite a number of people who also just need that intervention. It's a surgical procedure where you can correct that distortion of the eyelashes. We've also had severe patients with severe allergy, and this tends to cause people to seek traditional herb applications. And some of these herbs are either too concentrated, or some of them can be having germs in them. So when they apply this medication, sometimes the disease worsens, or the eyes develop a complication like ulcers, ulcers on the eye. So these camps give us opportunity to talk to the people, to raise awareness about these different conditions, but also to intervene for those who are already suffering from the different problems. I think we've achieved something, because the first camp, we had to do a lot of mobilization effort prior to the camp, and we still had a few hundreds. The subsequent camp, we did the mobilization, we went into the thousands. This time round, we didn't do a lot of prior mobilization, but the people are now just coming. So we've achieved something in the sense that people are now more conscious of the need to seek medical attention. And I think for us, that is a big step. If we can be a catalyst to enable people to take care of themselves, like knowing that I'm unwell in this respect, I should go and be attended to. And not even to wait for the camps. When we give health education talks here, we also give them information about where they can find help for different problems. And then as a long-time serving health worker, I also have my network. Sometimes I'm able to give them contacts, actually, of persons, and also contacts of institutions where they can be helped. We are working as a team together with the health workers on the ground, those who are here every day. So if there are patients with chronic conditions, we bring it to their attention. Like in our reports, we bring it to their attention, and then they can be followed up from here. So like we give the initial treatment, but we emphasize to them that, this is a chronic condition, you need to come back for checkup. And a lot of things can be done at this health center. But at the same time, as we interact with specialists from different institutions, we are expanding the network for the health center and also for the patients. When we invite patients to a health center, they have certain expectations. So in that respect, like when we looked at the toilet facilities, they needed facelift, so we contributed towards the painting of the toilet facilities. Yesterday we even did some repairs on some of the shutters, because we also take privacy as being an important thing. Somebody should not be in a toilet with, fearing that anybody could pop up and, interfere with whatever they are doing. So, so we contribute whichever way we are able with the resources that are available. It's one of the fulfilling experiences when we come and we feel we've intervened in some people's life journey, either by making a diagnosis or by giving them information. It's like a tribute to our parents who invested so much in our education and in our lives in general. So we also feel that we are part of this community, and the things that affect them also affect us. And then we also have that obligation that, yes, God has given us opportunity to be exposed and also to learn a lot of things. Let's use some of these experiences and knowledge to also improve other people's lives. My final word is really to the community. Let them take good care of their own lives. If there is anything that feels not quite right about their lives, they should seek medical attention immediately. We are blessed to have this health center here, and there are clinicians here, so they should come here as soon as they feel unwell and come quickly, because some of the diseases are more difficult to treat when they stay a long time. So that's to be my final message. Any ill feeling, feeling unwell over anything, they should come and seek medical attention.
My name is Dr. Harriet Kose Kayanja. Currently, I live in the United States. I'm an associate professor of medicine at University of Cincinnati in Ohio. My subspecialty in medicine is pulmonary and critical care. So I take care of the sickest patients in the hospital and those who have trouble with their lungs. This is my vacation time from work, so this is very dear and near to my heart. Like I mentioned, I was born here in Ivukula. My relatives live here, so I'm very much attached to the community, and so if it means, you know, I'm not relaxing on my vacation time and coming to help, that means more to me than spending time laying around on a beach. What I've learned over the years is many people are willing to help, and but you have to form relationships for them to hear the story. And so I don't have a TV platform or a big social media platform that I could crowd fundraise. However, all the fundraising is from my personal relationships with colleagues at work, with friends in the community, and I mean, I think you don't need to wait for a big platform to do something that's important. You can start wherever you are. I didn't come for the first one. I did fundraise though, but I came last year and brought a team, and I came this year and brought a team. And the team includes my husband, who is an orthopedic surgeon in the United States, and another young doctor. My hope and expectation is that next year I'll bring even a bigger team and hopefully create a collaboration with the institute where I work, so that some of the people who are training to be subspecialists can come with me, and residents and fellows who are interested in global health can come. So the need is great, and what we do seems like just a drop in an ocean. However, people will come where they are welcome. So we've opened a door, and some may not know what they need, but they know they'd feel unwell. And coming here, we found people who either came for back pain, and it turns out they have high blood pressure. So there are so many undiagnosed and therefore untreated illnesses that are in our community because they don't see a doctor on a regular basis. And so I think for now, the emphasis is that the need is great, and I'm hopeful that this is something that can happen more frequently, and also partner with people who are local to make this happen more frequently. I don't need to be here to make it happen.
My name is Mark Kayanja. I'm a general surgeon by original training and an orthopedic surgeon, and I currently work in the University of Cincinnati Medical Center as an associate professor in orthopedic surgery. It's the second time. I actually came last year for the same camp that we had about the same time last year. I've been involved in medical missions for a while. Originally, the first mission that we did was a spine mission that we did in 2006. And ever since then, barring COVID kind of shut things down. We were coming at least once a year to see patients and patients with spinal pathologies, treat them, and offer services. That was in Kampala and Mbarara. But we just came off a spine mission that we were doing last week at Mulago. So last week was doing spine surgery. I think the difference is there are larger numbers of patients this year, and our experience last year helped us plan for this year. So we are kind of more organized in terms of how we are triaging the patients, and we have separate tents for different specialities in anticipation of what we experienced last year. Well, I've predominantly been seeing some of the medical patients, but I've been seeing predominantly surgical issues, issues like hernias, issues like what we call non-unions, where somebody had a fracture before and didn't have it fixed, and the bones did not unite together, and now they have a limb which is flail and doesn't work because the bones are not joined together. We've also seen conditions like infections, dental infections. We've seen ear infections, and other conditions like back pain, which is one of the commonest complaints worldwide that we see in orthopedic surgery. So I do have a background that I spent some time both as a student and as a teacher in the university at Mulago, at the Makerere University at Mulago Hospital. So it's now the College of Health Sciences. Previously it used to be, Makerere University. But my involvement there has led me to have people who were previously my students and are now surgeons who I've remained in contact with, and these serve as a means of continuing the health care. So for example, from here we have patients who need referrals, there are patients who need hip replacements, there are patients who need orthopedic surgery, patients who need general surgery, and we do have those colleagues who are based here in Uganda who can help us with that. Our goal is to partner with them to help patients. So I think with that there are some facilities that offer services for the underprivileged patients, and we're really looking at partnering with them. There are camps, not only spine surgery camps, not only medical missions, but there are other camps with visiting surgeons who come from abroad, where they facilitate patients, especially the underprivileged, and the goal really is to liaise with them so that we can find out when the camps are, so that the patients can get into those camps. I think the most important thing is to identify the patients so that the healthcare workers here know who they are and how to contact them, so that when a camp comes round, they don't miss out on it. Some of the camps are, for example, they've had hernia camps at the Nsinzi Health Center. There are other kind of camps that take place, and I think it's important for the patients to know when those camps happen so that they can be assisted. I normally do not treat medical patients, but I still have my medical knowledge. So I did help out with treating some patients with hypertension. Some of the patients came in with soaring BPs, blood pressures which were excessively high, and my wife is a critical care physician, so I consulted with her and she helped me in treating those patients, and were able to get their blood pressures under control, which prevented them from having strokes and other, consequences of uncontrolled blood pressures. So I did see a young child who came in with what we call osteomyelitis. So osteomyelitis is a bone infection. So he was having an infection in his foot, and he was having discharge of pus from his foot. So the family was a challenged family. They did not have any resources, but through the mission we were able to provide him with support for him to be admitted. He was admitted for a few days to receive intravenous antibiotics. He received them for about a week, and then he was transitioned to oral antibiotics, and the recommendation is to have the antibiotics for at least 6 weeks to suppress the bone infection. So the mission was able to provide that for him, and I just got a follow-up from the nurses who saw him. They said he's much better now, he's going back to school, and that was really a heartwarming story. So he was walking barefoot, So he probably had, some kind of cut, scrape where bacteria could enter, and then he probably got the infection to start off as a small wound, which then progressed to a bone infection. It is costly, but in this instance, my history is that I worked in Mulago Hospital for my training, and I also worked there as a medical officer, and I was very much aware as to how osteomyelitis or bone infection, once it gets set in the bone, is a really difficult condition to eradicate. So seeing him reminded me that if we get it in the early stages and treat it aggressively with the antibiotics, we prevent long-term complications. And I was so glad that we were able to help this individual, and I think that made a difference. The health camp has been a good experience for us. The goal is really to help patients, and we are happy to see that there are partners that we work with here. The workers at the health center have really been helpful, but really our goal is to give back in honor of Zadok and Joyce Wabulembo.
To wind up the day, the team held a meeting in the evening and exchanged valuable insights and experiences among its team members, as well as what didn't go right that needed to be improved the following day for better patient outcomes.
My name is Dr. Wabutonga Charles. Today I was centered at triage and also assisted at the consultation table. That's medical. Today, to begin with, at triage, we noted that we made good progress of the organization because, one, we were able to issue out cards. As by the end of the day, we had issued 900 cards. So that means that today we saw over 1,500 or 2,000 people today. Remember, the cards were given to adults only. Then we also had a pediatric section. Maybe if we get also the updates from the pediatric department.
I worked in the pediatrics department. We saw 179 patients today, children. One of the main challenges we faced, first of all, our place was attacked, let me say, in quotes, by the patients and by the students and their attendants. So the VHT was an elderly man who couldn't handle the patients and the people coming in. So at a certain point, I was chasing away some patients and I'm telling them that I won't be able to attend to them.
My name is Mark Kayanja, and I was seeing surgical patients. The total was about 31 patients. Commonest complaint was back pain, leg pain. We did see a number of inguinal-scrotal hernias. We did see old fractures which had not united. We also saw not just inguinal-scrotal hernias, but other hernias as well.
We had a combination. We had those who came in to be screened and those who had other gyne issues. We avoided antenatal because we were going to crowd our tent. And we only saw those who had complications and referred to be seen. But for screening, we screened 67 women for cancer, and about 15% had pre-cancer, which we treated.
My name is Rachel Alinaiswe. I'm an intern pharmacist. So today we had our pharmacy split in initially 3 different locations, but then we had the 4th with the OBGY. Yes, so it really helped. Today I was not that tired like last time. Yes, so in PID pharmacy we're only able to see 134. I think we lost the 170 that we talked about from the doctor's section. I think because some of them were mothers, we kept on telling them, you go to the other pharmacy. That's how we ended up with 134. Then the general pharmacy had 501. Yes, 501 patients that were registered, though the last patients were not, we did not, I think the last 20 were not given drugs because we kind of divided. We divided that these drugs are going to the general pharmacy, then this one will go to PID, and we also divided according to days.
Dr. Ignatius, and I was with the medical surgical team. I've been thinking about the part where we have a patient needing more than one specialty. I had quite a number of those who want to go to the eye section, very many hypertensives with reduced vision, and we're thinking of hypertensive retinopathies, some diabetic retinopathies. And at the end of the day, what personally I thought we would be interested in when it comes to the statistics would be knowing the numbers and then the actual diagnosis for the different patients.
My concern is about the hypertension. I think it would be ideal by the time we leave this medical camp to suggest to the in charge of the facility, probably these people should open up a hypertensive clinic. That would ease the follow-up. So that we leave when we know maybe on this particular day they see those cases. The other concern is still there because when you look at the drugs applied to Center 3s, for hypertension, basically there are two, nifedipine and the bendroflurazide. And here we come with amlodipine, losartan, which is also very expensive, and other things. Okay, so that we also need to look into it. We had a woman whose lip was bitten off by someone, a co-wife, and she came in bleeding. Some basic things were done, the suturing, but the other piece wasn't brought, and so she wasn't helped in other things because we would have replaced it, but that wasn't done.
Health camps focus on preventable health care, which means that they identify and address health issues before they become severe. We shall share with you more highlights next time.
UBC, inspiring Uganda.